Good evening, everyone. Thank you for joining us for this webinar. I'm Marius Lebray, respiratory physiotherapist and head of innovation and research for MedLab at Air Liquide Medical Systems for the chronic care part, focusing on home ventilators and cough assistance devices. I am delighted tonight to welcome Mathieu Delorme to this fifth and final webinar of the year. Maybe Mathieu will connect to the session. There he is. Nice, perfect. Can you hear me clearly, Mathieu?
I do, that's perfect. Hi, everybody.
Hi. So Mathieu is both a friend and a colleague. So I'm quite happy to have Mathieu in this webinar tonight. He's a physiotherapist also from Bordeaux region, holds a PhD in science and splits his time between clinical work, research and teaching. As an author of several scientific papers and book chapters, his expertise includes ventilatory monitoring for neuromuscular patients and instrumental techniques in respiratory rehabilitation. Tonight, Mathieu will present on mechanical insufflation, exsufflation at home, and the title is Who, When, and How. So for which patient, when, and how should we implement that kind of treatment? And the presentation will last about 45 minutes, followed by 10-15 minutes of question. Feel free, of course, to drop your questions in the chat during the session so we can address them later. I think that's all for me. Enjoy this webinar. And Mathieu, I give you the floor.
Thank you very much, Marius. Hi, everybody. I will start sharing my screen just to make sure that you see everything. And Marius, give me a go when you see my screen correctly, but I think it's okay like this. Yeah. Just confirm me. Okay. So here again,
okay, Mathieu, you can go ahead.
Okay, that's perfect. Okay. Okay, so thank you very much. And I would like, first of all, to thank Air Liquide for proposing me this presentation. As Marius told you, I am a physiotherapist working in Bordeaux, in France. So I apologize for my accent, but I will do my best to make sure that everybody is able to understand what I will say in English this evening. So here are some of my conflicts of interest, mainly with the industry and, of course, including here Air Liquide for the purpose of tonight, and keep this in mind during the presentation. So there are three objectives for the presentation of tonight, and the first one will be to understand when we can think about implementing mechanical insufflation, exsufflation, so how we can identify the main indications for what I will call during the presentation the INEX. The second point will be to discuss how we can implement the insufflation, and so we will talk a little bit about the different settings available in the different devices. And the last point will be ultimately to understand for which patient we should propose insufflation, exsufflation. So I would like, first of all, to start with a very, very useful reference that I strongly suggest you to read and to keep with you, which included most of the international experts in the field of airway clearance techniques in neuromuscular disorders. So this is a really interesting state of the art in which you will find very, very useful information far beyond what we will be talking today. So the first part of the presentation will be to identify the indications for insufflation, exsufflation. And just to start with this fast reminder, I guess you all know that for having an effective and efficient cough, there are three important phases. The first one will be to take a deep breath in, to have a deep inspiration and to make sure that the air that we breathe in goes everywhere in the lungs. The second phase of the cough will be a phase of compression of the air that we will have in the thorax, and so there is a recruitment of the expiratory muscles as well as the upper airway that will need to be closed during this compression phase in order to increase the pressure inside the lungs. And the third phase will be an expulsion of the secretions with an opening of the airway to generate a peak expiratory flow that will be able to clear the secretions during cough. And if we look more precisely on this different aspect, the first thing is that we require a good inspiration. And what is a good inspiration? It means that we will inhale a sufficient volume and that the air that we take in will be distributed throughout the tracheobronchial tree in a homogeneous way to make sure that the air goes everywhere and in the important part of the lungs in which there may be some secretions to remove. So the inspiratory phase of the cough is a very, very, very important aspect. We often see cough as an expiratory mechanism, but keep in mind that the inspiration is really important. The second aspect which is important is that we should be able to increase the pressure around the lungs. This implies that the muscles participating to the expiration are functional, are not altered, and that we are able to close the glottis. I did put this under brackets because there are some cough that in which we do not need to close the glottis, such as the huffing, which implies that we generate an expiratory flow without the glottic closures. If I mimic this huffing, it's like, and so here there is no glottic closure. The third aspect, which is also important, is that we need to generate a sufficient expiratory flow, which will be able to loosen the secretions, which implies also a certain amount of power, and we will discuss about this in the next slide. And this also implies that the secretions have a sufficient rheology to be adequately removed from the bronchial tree. We will not focus on this topic today, but keep in mind that the way we manage the humidification of the lungs is really important in the management of airway secretions. And the last point is that during the cough, we will try to do our best, to avoid any collapses of the bronchi, of the trachea, but also of the upper airway. And we will take time to discuss this very problematic situation, particularly in the case of insufflation, exsufflation. So I told you that we would discuss about the importance of the power of cough. And if you take a look at this study, which was conducted in patients with neuromuscular disorders, you see here a flow volume curve of a patient who is here coughing with a perfectly normal cough. And what you see here is that the peak expiratory flow during cough reaches up to 600 liters per minute. And more importantly, you see that there are some spikes during the cough, which reflect the explosiveness, the explosivity of the cough. The second part of this illustration is here, a patient with a an amyotrophic lateral sclerosis, but with no bulbar involvement. And you see here that the cuff is only twice as low as the first one, only 300 liters per minute, and you are progressively losing the spikes. The shape of the expiratory flow is rounded here. You don't see the spikes that were here. And the last part is a patient with an amyotrophic lateral sclerosis, but with an important bulbar alteration. And you see here that the amplitude of the expiratory flow is lower and that you completely lose any spike. So what is the importance of that spikes? Why am I talking of this? Is that because when you look at the vital capacity of the patient, which is usually a surrogate of the lung function in such patients, you see that patients with or without spike, with in white and without in black, there is not much difference in terms of vital capacity. But when you look at the survival of those patients, you see that patients without an enough efficient cuff, as evaluated by the presence of spikes, have a survival probability lower than patients with preserved cuff efficiency. So it is much important to be able to compensate for the lack of efficiency of the cuff. So when should we consider insufflation, exsufflation devices? And I show you this slide, which is derived from the work of Michel Toussaint, Michel Chatouin, and as you see here, Gonzalez also. So you have the reference in every slide, and you will have access to this presentation later. When you look at this illustration, you see that there is probably two thresholds that you should keep in mind. The first one is here a peak cuff flow below 300 liters per minute. That's some of a threshold above which you should really consider the need for assisted cuff. And the second threshold that you see here is below 200, let's say 200, 180 liters per minute of peak cuff flow, below which it would be really not recommended not to think about assisted cuff. And this is probably the situation in which it would be a real error not to propose insufflation, exsufflation devices to the patient. As you can see, of course, the more assistance you provide to cuff, the more costly it is, and that's something that is quite straightforward. But it's important to remind that in patients who do not need mechanical assistance, there are some cheaper way to improve their cuff. But here we are talking today on the most severe patient, let's say those who have a peak cuff flow below around 200 liters per minute. So when we look about the airway clearance techniques, and this part is quite important to have in mind, airway clearance techniques are only one part of the respiratory physiotherapy. But if we focus on this, we can consider two main situations. The first one are those patients in which we need to mobilize sputum from the periphery, from the distal airways. And we have for this any manual techniques that physiotherapists know well, but also some mechanical aids such as high frequency oscillation, compression, intrapulmonary percussive ventilation, chest wall strapping, and more recently intermittent pulmonary deflation, but that is not the point of today. And the second main aspect is to improve cough. And we usually say that coughing will be effective for the 3, 4, 5 first dichotomization of the bronchial tree. So this refers to proximal secretions. And to help with this, we have the possibility of mechanically assisting or manually the inspiration, the expiration, or both the inspiration and the expiration. And so when we try to assist inspiration, we can assist the inspiration on single breath, such as with non-invasive ventilation or intermittent positive pressure breathing. This is something that we can do, but we also can do this with an insufflation-exsufflation device, and by using only the insufflation part of the INEX. This is also possible to assist the expiration with the physiotherapist, which will help manually the cough of the patient, or along with a mechanical exsufflation. And we also have the possibility to combine both inspiration and expiration with a mechanical assistance, such as the inexsufflation. So we will focus on this aspect. And the main principle of action of insufflation-exsufflation devices is that the device will provide a positive pressure during the insufflation, which is intended to increase the inspiratory volume of the patient. And this is important to consider that this aspect is at least as important as the exsufflation. So a good insufflation, which will generate a good inspiratory volume. The second part of the main basics of functioning of the insufflation-exsufflation is that the device will generate a negative pressure, which is intended to improve the expiratory flow. It is possible to do this with manual maneuvers, such as with the physiotherapist or with the care assistant of the patient or the family. And keep in mind that the synchronization between the pressure delivered by the device and the spontaneous breathing cycle of the patient will be an important aspect of the efficiency of the technique, and we have to make sure that the exsufflation comes at the right moment at which the patient goes from inspiration to expiration. So how do we do this? How can we adapt the different settings that are available in an insufflation-exsufflation device? Here you have an example of a snapshot of the screen of the EO 70 that you see at the top of the slide. And there are, when you start for the first time an INEX device, there are several modes that you can use. And the usual one, or when you start the device, you should start with that kind of mode, is manual modes. So you will by yourself switch from the insufflation to the exsufflation. And the insufflation pressure that you set in a manual mode will deliver the insufflation, which is the primary determinant of the pre-cough volume. And this is probably the third time that I insist on this aspect, but really keep in mind that the insufflation is really important when you do insufflation-exsufflation. The volume that will be inspired by the patient will depend on patient's effort, will depend, of course, of the pressure that you have set, but also on the patient effort. The volume will also depend on the compliance of the patient. Patients with really restrictive disorders will for a given pressure, inhale a lower volume. And will also depends on the leaks between the interface and the airway opening. And so when there is important non-intentional leaks, it is possible that the tidal volume monitored by the device will increase and will not accurately reflect what has been effectively inspired by the patient. So beware of the leaks and of the interpretation of the tidal volume with that kind of devices. And the second settings that you will meet in a manual mode will be the expiratory pressure. The expiratory pressure will be an important determinant of the peak expiratory flow, but the peak expiratory flow will also depend on the inspired volume, but also on the upper airway stability, and we will talk precisely of this aspect a little bit later. When you switch to an automatic mode, you will still set an inspiratory pressure, an expiratory pressure, and you will also set the time for insufflation, exsufflation, and a pause. So you will set those times. And this is not really a setting, but it is important to note that this kind of techniques can be used with different interfaces. The most broadly used are the masks, usually nasobuccal masks, but it is also possible to perform this therapy on tracheostomy patients. So how do we set the device? We will start with an interesting algorithm that has been provided by Anita Simons and Michel Chatouin, which are two British experts of this therapy. This is one of the few algorithms that have been published on this topic, so I propose you this one. And the first thing that they suggest to do is to set the insufflation pressure. And how do we set the insufflation pressure? We can start by looking at the non-invasive ventilation of the patient. If he is already on non-invasive ventilation, take a look at how the NIV is set, and you can start with 5 centimeters of water above the inspiratory positive airway pressure that is set on the NIV. This is a suggestion, and we can start with this. So let's say that the patient is ventilated with an IPAP of 15. You can start the exsufflation with an inspiratory pressure of 20, for example. If the patient has no NIV, you can start by 15, 20, it's okay, centimeters of water, and take a look at what is happening with the patient. Do you see a good mobilization of the abdomen, of the thorax? Does the patient feels like he takes a deep breath? Do you feel that the inspired volume seems enough for the patient? Don't hesitate to talk with your patient. How do you feel? Do you think it's the device provides you enough air? Feel free to gather the comments of the patient, which will be really informative. And if you don't meet this target, taking a deep breath in, increase by 5 centimeters of water and go above and above until you reach that kind of objective. When it's okay, you can start to set the exsufflation pressure. And so how do you set the exsufflation pressure? In order to start, and that's the suggestion of Anita Simons and Michel Chatouin, and I'm perfectly okay with that. Usually, the final settings are always with an absolute value of expiratory pressure a little bit higher than the inspiratory pressure. So let's say you've set 30 centimeters of water of inspiratory pressure. You can start with minus 35 centimeters, 35 or 40 centimeters of water of exsufflation pressure, and try to see if you meet the objectives of the exsufflation pressure. And what are the objectives of the exsufflation pressure is to increase cough. So do you see an increase in the audibility of the cough? Are some secretion brought into the mouth? Does the peak cough flow increase? The new generation devices propose to monitor the peak cough flow, which can be a good surrogate of the cough efficiency in case you don't have upper airway instability. So be prudent on the evaluation of the cough peak flow, but when the cough is okay, it can be a good information. And does the patient say that their cough is stronger? Is the cough efficient? Keep in mind that the target when we do insufflation, exsufflation is to bring sputum into the mouth, and is to help the patient breathe and help the patient remove its secretion. So we can use any surrogate that we want, but if your patient brings something into the mouth, that's okay. It's efficient, okay? Stay clinician with that kind of device. If you don't meet those targets, you can increase the expiratory pressure, and if it's okay, you can start setting the automatic mode. And so the automatic mode, it's all about setting the good insufflation time and exsufflation time. So if the patient is on an IV, what our colleagues suggest is to increase the inspiratory time of the NIV by 0.5 seconds for both insufflation and exsufflation time. So if the patient has an insufflation duration on an IV, which is, let's say, 1 second, you can set 1.5 seconds of insufflation and exsufflation. Start with a pause of 1 second. If there is no information, start with 111 or 222, no more than 2, but 1.111 is okay in terms of duration. And here again, ask your patient for his feedback. Is the insufflation long enough? Do you feel that you, as a clinician, when the device is giving some pressure into the lung of the patient, do you feel that during the insufflation there is an equilibrium between the device and the lungs of the patient? Does the expiratory flow is generated quick, fast? Keep in mind that the ratio between insufflation and exsufflation during cough is completely the opposite of a normal breath. When you breathe normally, usually the expiration is longer than the inspiration, but during cough, you will try to reach a long insufflation and a short expiration to have a peak flow during the cough. And what does your patient say regarding the pause time that you've set? So this is something that you should set with two persons, the clinician and the patient. And if you don't reach those targets, try to adjust the duration of insufflation, exsufflation, pause, to find the best compromise between the comfort of the patient and the efficiency of the cough. And when it's okay, you can start to try the insufflation, exsufflation with that kind of settings to make the patient familiar with the use of this automatic mode. And when it's okay, the patient can go back home and use it at home when it is necessary. This is the moment that I should tell you that when you start that kind of device with a patient, bring his next of kin with him and start to train people who will be with him or her at home. So what is a good insufflation? What is it? And we can here refer to this work of Méliès, which has been published almost 10 years ago, but which is still relevant. Here, this is a work that has been performed with intermittent positive pressure breathing, but the message is exactly the same for the insufflation during insufflation, exsufflation. And what they did was to monitor and to the vital capacity of the patient, the amount of air that they were able to take in by increasing progressively the insufflation pressure, and they tried to determine which was the best insufflation to generate the best cough efficiency. And as you can see here, it was never the maximum value that yielded the best results regarding peak cough flow, but it's somewhat somewhere below the maximum capacity. So the optimal insufflation pressure is sub-maximal. What is a good exsufflation? It's an exsufflation that will generate a good expiratory flow during cough. It will also depend, of course, of the insufflated volume. But here again, keep your clinical skills when you set those devices. And so is the cough effective? Is there some mobilization of secretions? It will be also important to take into account the non-intentional leaks that we can meet during insufflation, exsufflation, and to make sure that this is something that from a clinical point of view will be tolerable by the patients. An interesting work on this topic, and I had the chance to write with two colleagues, Isabelle Vivotseff and François Lelouch, an editor on this very important paper that has been recently published by our British colleagues on the insufflation, exsufflation technology. And they make a really physiological approach of the effects of insufflation, exsufflation. And what they showed in this work is that the peak expiratory flow, when you use high pressures, meaning plus or minus 60 centimeters of water, compared to low pressure, which was plus or minus 30 centimeters of water, the peak expiratory flow will be significantly higher with high pressure. We have some knowledge about this, but this is an important aspect of the work, but not the only one, as you will see shortly. They had here in this study 3 groups of patients: Duchenne patients on long-term tracheostomy ventilation, and patients with spinal cord injury. And the first thing that you see when you look at this is that the association between the efficiency of the peak expiratory flow and the pressure that is set on the device is much more significant in patients with tracheostomy ventilation. And the main difference between patients with tracheostomy ventilation compared to the 2 other groups is that they do not have upper airways. And so the patency of the upper airways is an important aspect, and we will insist on this point. Interestingly, they demonstrated with the use of electrical impedance tomography that there were no significant lung derecruitment by using high pressure, and this is an important information. We often had this concern that high exsufflation pressure could promote lung derecruitment, and so this is here a nice way to show that there was no significant lung recruitment when you use high pressures. If we look more closely at the volume expired by the patient, as you can see here, there was a large heterogeneity between the groups of patients. And here again, the patients which benefited the most of using high pressure were those on tracheostomy ventilation. Here again, because there were no interaction with upper airways. And this is the main problem of insufflation, exsufflation, is that when there is no airway collapse, you can see here flow volume loops. When there is no upper airway collapse, when you increase the pressure here, you will generate higher volume and not always higher flow, but higher volume. That's an evidence. But when there are some upper airway collapse, you can see here that the use of both high pressure or low pressure are able to generate the collapse, and so to reduce the efficiency of the technique. And the interaction between insufflation, exsufflation, and the upper airways is something that has been described 20 years ago for the first time by Sancho and colleagues here on CT scans, where you can see the collapse of the upper airways in patients during insufflation, exsufflation. And let's take a look at those videos from more recently by Tina Andersen with nasofibroscopy during insufflation, exsufflation. And as you can see here, during the insufflation, the upper airways are open. Here, everything's okay. And during the exsufflation, there is a glottic closure, and the patient is able to bring some secretion into the mouth. So this is a really elegant way to demonstrate the efficiency of the therapy here in a patient without bulbar symptom, without upper airway collapse. What is happening when there is here a pseudobulbar parese in a patient with ALS? You see during the insufflation that the tongue, the epiglottis, all the larynx tends to close during the insufflation. So there is not enough air inhaled. And during the exsufflation, of course, there will be an important collapse of the upper airways that will obviously reduce the efficiency of the therapy. So if we look at the literature on this topic, we estimate that the flow required to have a good efficiency of the cough is around 3 liters per second. And so if you keep this threshold in mind, and you see here a flow volume loop, as I showed you from the study of our British colleague with Shah as a first author, you see here the collapse of the upper airways. Okay, there is a peak and there is a collapse during the expiration. And so what can be interesting to investigate is how much volume is coughed with a flow which is efficient, meaning a flow above 3 liters per minute. And that's another way to estimate the efficiency of the cough, how much volume I am able to cough above 3 liters per second. Sorry, not per minute, per second. And in this study from Mathieu Lacombe and in the team of Frédéric Lofazo in Garches in France, they investigating this topic and increased progressively the exsufflation pressure on an inexsufflation device, and they observed 3 different patterns of expiratory flow during insufflation, exsufflation. The first one here, A, is those patients who will progressively increase the peak expiratory flow. When you increase the pressure, the peak expiratory flow increase, and is also accompanied by an increase in the volume, which is the area under the curve here, above 3 liters per second. So they both increase the expiratory flow and the expiratory volume above 3 liters per second. If we look at the pattern C, you see here that patient increase the peak expiratory flow, but with not much increase in the inspired volume, because there is a strong collapse. And the third one, B, are those patients who increase their peak expiratory flow, with, in the first increase of pressure, an increase also of the volume. But if you increase too much, you will find a reduction of the volume. And you can see here on this slide the A pattern, patients who increase their peak cough flow and their volume. But you can see in situation B or C that some patients will increase their volume with increasing peak cough flow, but also to a certain amount reduce when you further increase the expiratory pressure. And note here that the number of subjects who were able to undergo the trials of large expiratory pressure, the number of subjects was significantly reduced, which suggests a reduction of the tolerance when you use really high insufflation or here exsufflation pressure. When we look at the those behavior of the expiratory flow on a bench model, and I showed you this data from Nicolas Terzi, here again in the team of Frédéric Lofazo, a work that I had the pleasure to work on. And when you measure the efficiency at the trachea level, so between the lungs and here a collapsible chamber, when you increase the pressure, you also increase the peak cough flow. And you see this both in the situation of upper airway collapse or without upper airway collapse. Independently from the upper airway collapse, and when you look at the trachea level, when you increase the pressure, you increase the flow. This is something that seems obvious, but let's look at what the device sees, because the device does not monitor the flow at the trachea level. The device monitors the flow at the device side. And what you can see here is that when there is no upper airway collapse in black, or when there is an upper airway collapse, the cough peak flow measured by the device tends to increase. This is completely paradoxal. When you increase, when there is an upper airway collapse, the flow monitored by the device tends to increase. Meanwhile, the volume expired above 3 liters per second is obviously reduced when there is an upper airway collapse. So there is a paradoxical fact when there is an upper airway collapse, that the device will monitor a wrong expiratory flow. This is the actual expiratory flow, but it is not. It does not go along with a good volume. It's only what comes out of the mouth. So it's important to keep this in mind, that the monitoring, and this is the main message of this paper, the monitoring of the peak cough flow is not interpretable, should really be interpreted with caution in the situation of upper airway collapse. There is also an important aspect regarding the impact of expiratory effort of the patient or of the patient and the physiotherapist. And in this work of, here again, Mathieu Lacombe, you see that the peak cough flow, when you use an insufflation with the physiotherapist tends to here decrease when you use an insufflation and an exsufflation. Here again with the respiratory therapist. It is not quite clear on the inspiratory capacity, but regarding the peak cough flow, it seems like there is a reduction of the efficiency here compared to an insufflation alone. And how can we interpret these results? Let's refer here again to the situation of a forced expiration. And you have here the flow of the patient. The patient here is coughing. And during the cough, when you look into details, you see here that there is a moment at which there is a positive pressure when you use both the exsufflation and the hands of the physiotherapist. And how can we explain this? It's like this. It's like if there was a resistance of the circuit that was not able to absorb all the expiratory flow that comes out of the patient and both the physiotherapist. And what you see here is that the patient who reduce their cough efficiency with inexsufflation compared to insufflation alone are those who had already really good cough efficiency with an inspiration alone. And the message here, which is perfectly in line to the data of Sancho that I showed you a little bit earlier, is that the patients who are able to generate a peak cough flow greater than 3-4 liters per second with an insufflation alone will not benefit from insufflation, exsufflation. It can be counterproductive because you will generate a positive pressure during the cough effort. So all in all, and I will conclude on this aspect, which will be quite quick, because who should be proposed the insufflation, exsufflation? And when we look at the most recent recommendations that have been published, and I'm sorry that those one are in French, but that's really the last one published this year by the group Respiratory Physiotherapy of the French Pulmonology Society. And as you can see here, there is no mechanical assistance recommended in COPD, asthma, cystic fibrosis, bronchiectasis, and the insufflation, exsufflation is recommended in patients who have cough deficiency in case due to neuromuscular disorder. So what can we do with this? You should say to me, all this for that. And probably that's not the good question. And maybe the good question is not what for whom, but what for what. What do we expect of the insufflation, exsufflation? And when we have to deal with sputum retention, we have basically 5 mechanical possibility. The first one will be to increase inspiratory volume, to increase expiratory flow, oscillations, to increase end expiratory lung volume to prevent recruitment, and eventually suctioning. And so the inexsufflation device will address those 2 aspects. And so probably that the indications rely on what we want to do with the patient. We want to increase in inspiratory volume. We want to increase the expiratory flow. And so in those situations, maybe that it would be more efficient that the medical diagnosis of the patient. Let's think about the function. So I will conclude on this topic just to remind you that if you missed the beginning, I strongly suggest you to refer to this state-of-the-art, which is really, really an interesting reading. And in 2 words, go back home with the following message. The first one being that you only clear what you ventilate. It's important, if you want to clear secretions, that there are some air that goes in the right part of the lungs. So it's important to remind of the importance of inspiratory time, of the pre-cough volume, and of the interaction with the upper airway. So keep in mind the aspect of monitoring data, and especially of the interpretation of the peak cough flow, which is debatable in situation of upper airway collapse. The use of high pressure tends to increase the efficiency of the device and tend to increase the peak cough flow. It's important to be clear on this aspect, that there is no de-recruitment issue, but it may increase the risk of upper airway collapse, and the efficiency of the therapy can still be clinically relevant by reducing the pressure that you use in the situation of upper airway collapse. So when there is a huge upper airway collapse, don't hesitate to reduce the pressure that you use. And last but not least, keep in mind that patient can require some assistance when you are not there. When this is public holidays, when they will probably need you during Christmas, and you will probably be doing something else. So it's important to consider the importance of continuity of care for such patient, but also, and most importantly, I would like to insist on this aspect, to train the caregivers, the family carers, the care assistants, or the physiotherapists working on a community-based office. It's important to have a good relation between the experts, which often work in the hospital settings, and the day-to-day carer, which will probably the most important part of the care for those patients. And I end with this. Sorry, it was a little bit longer than expected, but I guess that I hope that it will be useful for you, and thank you for your attention.
You hear me, Mathieu?
I do.
Okay, thank you. Thank you very much for this very interesting presentation. So I will go straight to the point. I will maybe we will address the questions, because we will run out of time at some point. So there are several questions in the chat that are quite interesting. Let's start with one of the first ones, which is, how important is the mask if leaks have such an impact? Because you say that the leakage with that kind of therapy had a huge impact. So how do we deal with the mask and the leakages, and maybe also with the data that are monitored on the screen of those devices?
Yeah, it's really important to. That's a good question, and this is important to consider that when there is some non-intentional leaks during the insufflation, the tidal volume that will be monitored by the device will always be overestimated. And so this should not be the main point of interest when we do the therapy. This is not really a problem that there is non-intentional leaks. When you do some insufflation, exsufflation, you will put on and off the mask, and on and off, so you don't have to tighten the mask. This is not the best way to do this, but just stay clinical and look at your patient. Does the patient takes a deep breath in? And that's the most important information, far better than the tidal volume monitored by the device.
Okay, thank you. And there is also a risk of, I don't know if you experienced that, but there is a risk that the machine would not be able to deliver the set pressure also. If there is a huge amount of leakages. So you also need to be aware of that.
Fully agree with this.
Next question. It's also an interesting question related to what you explained during your presentation, is how do we detect a premature expiratory collapse?
So this is a really good question. The expert in the field, especially in Europe, are more and more claiming about introducing in the devices the flow volume loops. And as I told you, when you look at the flow volume loops, it's quite easy to see the collapse because the flow will stop prematurely. So this is something that is quite easy to see on a loop, but it's I think even more easy to see on the patient. A patient which collapsed during the cough will stop quickly. Eventually, the tongue will go out of the mouth, and if I should show you, that's quite quick to see.
You're a good actor.
Thank you very much. You can also do this with nasofibroscopy, such as the team of Tina Andersen, etc. That's a good way to show the things, but I guess that in everyday practice, it's a little bit complicated to implement.
Yes, sure. Okay, thank you. Joseph is asking us, can you tell us the importance of the oscillation? So oscillation during inspiration and also during expiration, expiratory time. And if there is any recommendation to use it, and if so, I guess, in which frequency and amplitude?
Yeah, thank you for this question, because it is an option that has been made available on several devices. To the best of my knowledge, there is no clear recommendations on this aspect. This is something that the rationale is to ease the mobilization of the secretion. From a practical point of view, when we don't see in the literature any benefits regarding that kind of features, and in my personal experience is that it's not something that I should recommend to start with on a usual basis, because the benefits are really not clear. But here again, let's say pragmatic and test it with the patient. If the patient is happy with that, let's keep him happy.
Yeah, sure. I'm totally aligned with this. There is no evidences backing it up, but at the end, it's also the patient's comfort and feeling, and it could, in some situations, for some patients, improve the feeling and maybe the therapy. So I think we should, when it's possible, give it a try.
But I can suggest you on this topic an interesting reading from Michel Toussaint and Michel Chatwin, the two Michels of the MIE, which is the title, if I remember well, is will oscillation be ever beneficial during insufflation, exsufflation? So there is something like this. You will find this paper. That's a technical note on this topic, which is interesting to read.
Thank you. So let's take two last questions, because that's going to be almost 7. Rudy is asking, do you have any information on the risk of pulmonary barotrauma with the inspiratory pressure of an MIE device on COPD patients, meaning with severe emphysema?
This is a good question, which leads to, I think, two concerns. The first one being the pressure effect in patients who have a barotraumatic risk. This is, I did not, I should have put a slide on the contraindication of the insufflation, exsufflation, but patients with recent barotrauma, or in which we feel that the use of high pressure could be deleterious, it is obviously contraindicated to insist. But the second aspect is that patients with COPD have also an obstructive pattern, which probably will alter the bronchial patency during exsufflation, and so I'm quite confident that the efficiency of insufflation, exsufflation will be reduced to a minimum in that kind of patient, and here again, that kind of therapy is not recommended in those patients.
Well, thank you very much, Mathieu, for this presentation and for having responded to the questions. Thank you, everyone that are connected and that were connected to this webinar. It was a pleasure to host this webinar with you. Thank you to Air Liquide Medical Systems and EOV, and I wish you all a nice evening.
Thank you very much, Marius. Thank you to Air Liquide. Bye-bye.
Bye.